Today I'll be speaking mainly on the issues of kidney transplantation. Long-term outcomes are superior with kidney transplantation as compared to hemodialysis in both quantity of the survival lifetime and the quality of the life. So the current absolute contradiction to kidney transplantation are: number one, active sepsis. If there is number two is current uncontrolled malignancy in the patient. Number three, uncontrolled psychosis in the patient. Number four, active drug dependence of the patient on the drugs. Number five, any medical condition with shortened life expectancy less than 1 to 2 years is again absolute contradiction for positive T cell CDS cross match. Again becomes a contradiction, otherwise kidney will be lost immediately. Historical contradiction to transplantation are HIV, hepatitis B and C. These days we consider patients of HIV also and hepatitis B and C those who have been cured. Obesity is another one, which used to be one of the contradictions. Now it's a historical contradiction only. We can conclude the obesity also in the transplant program. Mood disorders, older than 60 years they have written, but age is no bar for transplantation. Transplantation can be done at any age. People have done transplantation even at the age of 80s. We do the transplantation up to around 70 or 72 3 years. 72 and 73 years tak kar dene. Mood disorders again is a relative contradiction. Age older than 60 years is already told. Previous malignancy, if it is there, then if it is a treated malignancy, then it is not an absolute contradiction. It's a relative, it's a historical contradiction only. Blood group, if incompatibility, again is not considered a. We transplant incompatible blood transfusion, blood groups. We go ahead with the transplantation after removing those antibodies which are there in the body of the patient. Then guidelines for treatment of patients with previous malignancy. Usual wait time is for 2 years. In most cancers, we wait for 2 years before we go for transplantation. If no wait time is necessary in some situations like incidental renal carcinoma, if you find renal carcinoma on incidental renal carcinoma, we go ahead with the surgery. In situ carcinoma, focal neoplasms, focal areas only, low grade bladder tumor and basal cell skin cancers. These are 5 conditions where we do not wait any more. We go ahead with the transplant surgery. Wait time more than 2 years. There are some situations where we have to wait for more than 2 years. In most malignancy, we wait for 2 years maximum. But there are 4 conditions where we wait for even longer. One is melanoma. Recurrence is very common. So melanoma patient having melanoma, particularly in a very sensitive area like the face, then we wait for even longer period, longer than 2 years. Breast cancer again we wait for more than 2 years. Colorectal cancer again we wait for 2 years. Uterine cancers we wait for more than 2 years. Then screening for occult infection. What screening do we do for occult infection? Routine serology like CMV, EB virus, herpes, hepatitis B virus, hepatitis C virus and HIV. These are few viral infections which we investigate routinely by serology. And if they are found to be positive, then we consider that we cure them first before we go for transplantation. Now, where other viruses which are indicated also. HTLV is again we have to go for in given situations you have to look for HTLV, and similarly for herpes virus, human herpes virus and malaria, schistosomiasis, strongyloids and tuberculosis. These are few of the. We get X-ray chest in all these patients and urine culture is done for infections. Potential recipient evaluation and stress echo. Potential recipient evaluation while the patient is awaiting transplantation. So one may go ahead with stress echo at the time or thallium stress. One may go for angiography if indicated. Then cancer surveillance is related to the age, sex and of the patient. PSA is done for males, mammography in females, pap smear in females, colonoscopy in males and females both, skin cancer evaluation both males and females. Comorbidity research methods. Viral herpes zoster is we look for herpes hepatitis, viral hepatitis we look for, we get that LFT done, alpha beta proteins again for malignancy in the liver and ultrasound, LFT and ultrasound, HIV, C4D, CD4 count and AIDS. CD4 count is done mainly for HIV patients again. Then classification of the donation after cardiac death. One is uncontrolled. Uncontrolled category, patient is dead or arrival. At arrival, patient dies in the hospital. Category 2 is unsuccessful resuscitation. You have resuscitated the patient but unsuccessful resuscitation. We call that category 2. Category 3 is awaiting cardiac arrest. Patient comes to the hospital, brought to the hospital, but patient has not developed cardiac arrest. So we wait till that period, till the patient develops cardiac arrest, and then we go ahead with this. Then cardiac brain dead patients, of course. Then you remove the once if we declare the patient dead, brain dead, then we can stop the ventilator, etc., and we can go ahead with the cardiac. We can retrieve the organs in that situation. Then unexplained carcinoma in critically ill patients. These are some of the contradictions. Then we have evaluation of the donor. Medical history, we could look for whether patient is hypertensive or not, patient is diabetic or not. We look for malignancy if it is there. Then these becomes a contradiction further. Infections, past and current infections, TB, hepatitis B, and HIV virus. Transfusions, trauma. Then social history like IV drug abuse, alcohol and smoking, sexual behavior, tattoos made they are cause of malignancies, acupuncture, etc. rarely, overseas travel or incarceration. And lab investigation includes serum creatinine, urine and urine culture, urine routine and urine culture, LFT coagulation profile, blood culture, looking for parasites, etc., fungi, TB, ECG, X-ray chest, and biopsy if required. So these are few of the problems which we face in a cadaveric transplant program. Living donor examination is simple. Look for it, measure the blood pressure, see whether the patient has diabetes or not, look for infection, look for cancer, look for vesical bladder disease, look for renal stones, and look for gout and urinary tract infections. Then medical history, whether patient has taken NSAIDs or is taking NSAIDs regularly. Then smoking, illicit behavior or IV drug use, sexual history, exercise, whether the patient does good exercise or not, those are relevant in the. So examination, again look for the examination of the cardiovascular system, chest system, lungs, abdomen, etc. These are the systems which we like to examine in detail before we go for transplantation. Of course, because transplantation gives a normal life to the person compared to hemodialysis, where patient has to go for dialysis every third day. So it's not only normal life, it's a long life. It's a long life with good quality. It's a good quality, or it's a normal life, absolutely normal. Patient leads a absolutely normal life, not have to go anywhere ultimately, and lives a life for a long period of time. So we always say, if it is a life related program, then if father, mother are donating the kidney or brothers, sisters are donating the kidneys, that kidney survives for 30 years. If wife is the donor, that kidney survives for 15 years, but we can take it up to 30 or 20 years only. Unrelated one, the survival time used to be 8.8 years on cyclosporin A. Now we don't use cyclosporin, we use tacrolimus, which is a better drug. So with the tacrolimus, the survival time of the cadaver transplantation has come up to 15 years, 14.8 years in fact.